Welcome. Today my topic of discussion is osteoporosis. This is a slide we see here. A man is suffering from low back pain, most likely due to osteoporosis and its complication. The slide is telling us be aware of the silent disease. Before going to the actual discussion of osteoporosis, we have to know about the cells related with the osteoporosis. First, come to the discussion of osteoclast and its origin. Let us see the hematopoietic stem cell going to form the osteoclastic precursor cell, going to form mononucleated osteoclast, then multinucleated osteoclast, and finally bone resorbing osteoclast. This is osteoclastogenesis. Then come to the osteoblastic side, mesenchymal precursor forming committed osteoprogenitor cells, or pre-osteoblast, mature osteoblast going to form osteocytes, bone lining cell, and apoptosis or cell death of the mature osteoblast. So this is osteoblastogenesis. Here we see the healthy bone with internal structure, Haversian canal surrounded by osteocytes, osteoblast, osteoclast. They are maintaining harmony between bone formation and bone resorption, thus maintaining normal bone architecture. Now come to the osteoporotic side. Here we see the osteoblastic cells are there, osteoclastic cells are there, but osteoclastic cells are more in number, so there is more osteoclastic activity. As a result, there is porosity in the bone, and we will see the osteoporotic bone picture. This is the classification of osteoporosis, primarily divided into primary osteoporosis and secondary osteoporosis. Primary osteoporosis is again subdivided into type 1 or postmenopausal osteoporosis and type 2 or senile osteoporosis. And the secondary osteoporosis is due to secondary effect of drug or disease. Osteoporosis prevalence in India, 8.5% male over 50, that is 1 in 12, whereas 20% of female over 50 years, that is 1 in 5. You can see the difference of osteoporotic prevalence over male and female. Definition: osteoporosis is defined as a reduction in the strength of bone that leads to an increased risk of fracture. WHO operationally defines osteoporosis as bone density that falls 2.5 standard deviation below the mean for young healthy adult of same sex and race, also referred to as T-score less than -2.5. Bone mineral density determination, so many methods. Dual energy X-ray absorptiometry, that is DEXA scan, is the gold standard, and BMD scan done in spine, hip and wrist. The machine of DEXA scan, X-ray detector system above and X-ray source below. This is the slide showing DEXA principle. Radiation falling over the body. Body means bone and soft tissue. From this radiation, we are getting high energy attenuation profile as well as low energy attenuation profile from bone and soft tissue. And after getting the high energy attenuation profile, we have to multiply this with the kappa factor, that is the ratio of soft tissue attenuation at low and high energy, and subtract this from low energy attenuation profile, and the value is bone mineral density. Come to the T-score. If bone mineral density values of young, this is like 30 years healthy candidate of same sex and race are taken and plotted, the data of bone mineral density values will be distributed in a bell-shaped manner, where the peak or zero of the curve determines the most probable events in the data set, and the other data are evenly distributed on either side as 1 standard deviation, 2 standard deviation and 3 standard deviation. Now measure the bone mineral density of any particular patient and plot the value over the previous reference bell-shaped curve which I have shown in the previous slide of same sex and race and determine its actual position. If the BMD value lies on the left side of the zero, it is weaker bone than average, or if it is on the right side, it is stronger than average. So from conclusion, we say that values lies between 0 to -1, it is within normal range. Values lies between -1 to -2.5, it is osteopenia or low bone mass. If the value is less than -2.5, it is osteoporosis. If less than -2.5 with fracture, it is severe osteoporosis. Indication for BMD testing: men aged 70 years or more, or women aged more than 65 years, postmenopausal women or men aged 50 years or more with osteoporotic risk factor or fracture. Adults having risk of secondary osteoporosis as having disease or any drug which are enlisted for osteoporosis as side effects. Osteoporosis risk factors: non-modifiable list, advanced age, female gender, postmenopausal state, ethnic group. Modifiable list: this current cigarette smoking, alcoholism more than 2 drinks a day, low calcium intake, low vitamin D intake, inadequate physical activity, estrogen deficiency before 45 years, drugs and diseases causing osteoporosis. Disease or condition associated with osteoporosis: chronic obstructive pulmonary disease, rheumatoid arthritis, thyrotoxicosis, diabetes mellitus, multiple myeloma, multiple sclerosis, immobilization, and pregnancy lactation. Drugs associated with osteoporosis: first in the list, glucocorticoid, excess dose of thyroxine, thiazolidinedione, this pioglitazone, proton pump inhibitor, SSRI, anticonvulsants, heparin, lithium, and some chemotherapeutic drugs. Osteoporosis morbidity: back pain resulting from vertebral fracture due to trivial trauma or simple movement like weightlifting, loss of height from vertebral fracture, deformity from kyphosis or scoliosis, example Diverger's thumb, extraparenchymal restrictive pulmonary function, easy fracture of extremities, dependence on narcotics and non-narcotic analgesics, loss of self-esteem, body image, and independence. Slide showing prominent cortical outline, arrows, prominent vertebral end plate shadow with lucent trabeculae, arrows, suggestive of osteoporotic bone. Osteoporotic wedge compression collapse. I have shown here the X-ray, dorsal vertebrae, 2 vertebrae are shown here. Only the anterior part of the vertebra is collapsed. This is the wedge compression collapse. As a result, kyphosis. You can see an old lady is suffering from kyphotic deformity as a complication of osteoporosis. Osteoporotic crush compression collapse. 3 vertebrae are shown here. Entire vertebra is collapsed from anterior to posterior. This is the crush compression collapse. Ballooning of intervertebral disc causing fish mouth appearance. Arrows show the intervertebral disc with fish mouth appearance. Vitamin D and calcium. We know that we are getting vitamin D from sunlight. We are also getting vitamin D from the diet. Vitamin D come to the liver for 25 hydroxylation. After 25 hydroxylation, it goes to kidney for 1 hydroxylation. And after 1 hydroxylation, it is converted into 125 dihydroxycholecalciferol, goes to intestine for dietary absorption of calcium. As a result, serum calcium level will rise. If there is hypocalcemia, it stimulates the parathyroid gland. As a result, There is secretion of parathormone which acts on the kidney, causing increased calcium reabsorption, and serum calcium level will rise again. Parathormone also acts over the bone. Demineralization of the bone occurs with calcium release, and again serum calcium level will rise. Thus, hypocalcemic episode via parathormone causes rise of serum calcium through kidneys and bones. Calcium rich food, dairy products like milk, yogurt, cheese, beans, figs, broccoli, soy milk, spinach, and nuts and seeds like almond and sesame. Calcium, daily requirement of elemental calcium. I want to highlight about the elemental calcium, that is 1300 milligram for 9 years to 18 years to achieve peak bone mass in adolescence to avoid future risk of osteoporosis. And for 19 years to 50 years, it is 1000 milligram, and for 51 years onwards, it is 1200 milligram for balancing bone formation as well as resorption to avoid osteoporosis. Calcium, low calcium intake detected by low serum calcium level, that is less than 8.8 milligram per deciliter, and 24-hour urinary calcium excretion if it is less than 50 milligram. Now the calcium supplementation. Regarding calcium supplementation, we have to decide what the elemental calcium percentage in calcium salt. In calcium carbonate salt, it is 40% elemental calcium. In citrate, it is 20% elemental calcium, and it is in gluconate, it is 8% elemental calcium. So we have to decide the amount of elemental calcium before giving or prescribing the calcium salt, because we actually need elemental calcium, not the salt. We need elemental calcium. So before advising the calcium salt, we have to measure or calculate what amount of elemental calcium patient is getting. Regarding vitamin D, diet alone rarely contains sufficient vitamin D to maintain the adequate target of serum vitamin D 30 nanogram per milliliter. Thus, it needs supplementation. Optimal daily vitamin D intake should be 1000 to 2000 international units. Vitamin D helps in calcium absorption from intestine. Pharmacotherapy, osteoporosis, postmenopausal state with multiple risk factors for osteoporosis, postmenopausal state with fracture. Pharmacotherapy, anabolic agent which stimulates the osteoblastic activity, teriparatide, abaliparatide, romosozumab. Anti-resorptive agent which inhibit osteoclast activity, estrogen, selective estrogen receptor modulator, that is tamoxifen, raloxifene, bisphosphonate, alendronate, risodonate, lolendronate, and ibandronate, calcitonin, and denosumab. Prevention treatment of osteoporosis, bone healthy lifestyle to be maintained by well balanced diet, exercise, avoid bone toxins like cigarette and more than 2 drinks alcohol a day, daily elemental calcium intake 1200 milligram average, daily vitamin D intake 1000 to 2000 international unit. Pharmacotherapy when indicated, first line of therapy is bisphosphonate, second line teriparatide, third line raloxifene, and fourth line calcitonin, which are only used in women. In this slide, we will see the different drugs and their mechanism of action at different levels. In the left side, we see here the precursor of osteoblast going to form the osteoblastic cell. The right side, the precursor osteoclast going to form the osteoclastic cell. We know that rancle is being formed from the osteoblastic cell, which acts on the osteoclast, and thus the osteoclasts are activated and causing bone resorption. First come to the drug teriparatide. Teriparatide stimulates osteoblast. Next is the denosumab, which binds rancle so that rank fails to bind with the osteoclast and osteoclast activation does not occur, there will be no bone resorption. Next is the bisphosphonate. It inhibits osteoclast. Raloxifene or tamoxifene inhibit osteoclast. Calcitonin inhibits osteoclast. After inhibition, there will be death of osteoclastic cell. We also know it as apoptosis or cell death. So, we have seen the different drugs and their different site of action. It is an anti-resorptive agent, impair osteoclast function and reduce osteoclast number also. Used for osteoporosis prevention as well as treatment. May be taken as daily, once in a week or once in a month schedule. Oral medicine to be taken in empty stomach with full glass of water and remain upright for 30 minutes to avoid esophageal irritation. Potential side effects are osteonecrosis jaw and subtrochanteric femoral fracture. Not given if EGFR is less than 30. That is not given in CKD stage 4 or stage 5. Glucocorticoid-induced osteoporosis. Glucocorticoid increases bone loss as it inhibits osteoblast, stimulates osteoclast, impair gastrointestinal absorption of calcium and increase urinary calcium loss. All patients on long term, that is, I want to mention that more than 3 months of steroid treatment are susceptible. Prevention by lowest dose of glucocorticoid with more healthy lifestyle. FDA approved bisphosphonate for its prevention as well as treatment. Home message. Adequate calcium and vitamin D for all, either in diet or supplements. Say no to bone toxins, cigarette and alcohol more than 2 drinks a day. Simple proper bone X-ray with prominent bony cortical outline or vertebral end plate shadows with trabecular lucency we may think for osteoporosis. DEXA scan is the gold standard for bone mineral density and if the T-score is less than minus 2.5, it is osteoporosis. DEXA scan is advised for number 1, 70 years or more male or 65 years or more female. Number 2, 50 years or more male or postmenopausal female with fracture or risk factor for osteoporosis. Number 3, adult with risk for secondary osteoporosis. Pharmacotherapy is reserved for number 1, osteoporosis, that is T-score less than minus 2.5. Number 2, postmenopausal female with fracture or risk factors for osteoporosis. Bisphosphonate is useful for prevention and treatment of steroid-induced osteoporosis. Thank you to all.